Hi, welcome back. I think we'll start our session, and I'll reintroduce Professor Richard Wiggins, Associate Dean of CME at the University of Utah School of Medicine and Professor of Radiology and Imaging Sciences, who holds adjunct appointments in otolaryngology, head and neck surgery, and biomedical informatics. He's going to start off our cranial nerve session with a talk about the imaging of my favorite cranial nerve, the fifth cranial nerve. So welcome.
That's your favorite?
It is my favorite.
That's my favorite too. Okay, so we're going to start off the session with cranial nerve discussion. Very complicated cranial nerves, except 1 and 2. Those are mostly boring. We're going to talk about the other ones. And we're going to go back and forth to go through this very complex anatomy that we think about with cranial nerve. So I'm going to start with cranial nerve 5, the trigeminal nerve. I have nothing significant to disclose. And we're going to talk about the anatomy and then talk about the pathology that happens to that anatomy of the cranial nerve. And that the idea here, anytime you have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So for most of those, if you start behind the pontomedullary junction and go through the face, you've usually covered the area of interest, especially if you get 5 and 7 confused, and we'll talk about that. Is it pain or is it paralysis? But we think about the middle cranial nerves, 5 through 8, having their central nuclei in the pons. So 1 through 4 above that in the mesencephalon, and 9 through 12 being below. So the idea is anytime somebody has an isolated cranial nerve deficit, so 1 cranial nerve is out, maybe 2 or 3, not like they're not moving half their body, that's a big stroke, that's different. But anytime there's an isolated cranial nerve, we want to image from the origin nucleus all the way out through the end organ. So we're going to talk about all these cranial nerves, where they originate, what holes they go through, and where they go. And then we're going to look at examples of pathology that happen of those cranial nerves. And we're going to go through all of these from 3 to 12. So we're going to start off talking about 5. And all of these cranial nerves, we talk about having an intraaxial segment, a cisternal segment, often an intradural, and then an extracranial segment. And you'll see we'll have the same discussions about all these cranial nerves. The important thing is to understand that anatomy, and you can go look it up if you need to. But if you image from behind the pontomedullary junction through the face, you've usually covered the area of interest for those cranial nerves. So I'm going to start off talking about cranial nerve 5, the trigeminal nerve. And we have 4 central cranial nuclei that contribute to 1 fifth nerve. There's 3 sensory and 1 motor. So we have a main sensory nucleus that we think about as the heavily myelinated fast twitch, touch and pressure. There's a mesencephalic nucleus that we think about as mechanoreception of the teeth and proprioception of the TMJ. And there's a long spinal nucleus that we think about as less heavily myelinated, slow twitch, pain and temperature. And then there's a little motor nucleus, and all of the motor nucleus goes out with V3 down through ovale that we'll talk about. So there's 4 central cranial nuclei that contribute to 1 trigeminal nerve. So we have an intraaxial segment, then we have a cisternal segment, and it goes through the porus trigeminus, the opening to the trigeminal cave, or Meckel's cave, if you like to name stuff after people. And then we have the V1, V2, and V3 that goes distal to that level. So we have an intradural segment where we have the semilunar ganglion or Gasserian ganglion, and from that level, that's where V3 goes down inferiorly. So this is our trigeminal nerve. So if we take our hand and we tuck in our pinky and ring fingers and we point our thumbs down, that's your trigeminal nerve. So if you're ever trying to teach that, if my chest is the pons, this is the cisternal segment, we have a semilunar ganglion, V1 and 2 go forward to the cavernous sinus, and V3 goes down through ovale. So this is the trigeminal nerve. So in the US, when we see our other head and neck imaging buddies, we get like, yo. So that's how we think about that. So that's the ganglion, the semilunar ganglion. And after that, we have V1, V2, and V3. So there's an ophthalmic, a maxillary, and a mandibular nerve that's distal to that level. So the ophthalmic nerve V1 goes up through the supraorbital fissure, and then it goes up above the annular tendon or ring of Zen, where all the rectus muscles connect in the back. And that sensory to our forehead actually goes down to your tip of your nose. So that's V1 distribution. So V2 goes through the rotundum canal. People call it a foramen, but it's obviously a tube. It's a canal, not a foramen. So V2 is going through the rotundum foramen to get to the cavernous sinus, and that's sensory to the cheek and the upper teeth. And V3 is going down through ovale, through foramen ovale inferiorly, and that's giving sensation to all of our teeth and the jaw down low. So V1 our forehead, V2 our cheek, and V3 over the jaw at that level. So V3 is going down through ovale inferiorly, and it goes over to the mandible at that level, and then it comes out the mental foramen there anteriorly. So we think about at the level of the cavernous sinus, these valveless venous sinusoids, you have cranial nerve 3 in the oculomotor cistern, and then 4, and V1 and V2 are down the lateral dural surface of the cavernous sinus at that level. So here's an axial graphic showing those big fibers. So trigeminal nerve, the biggest nerve coming out on both sides of the pons, and those different nerves that go through. So V1 going through the supraorbital fissure, V2 through rotundum, and V3 down through ovale. And that goes forward to the pterygopalatine fossa. That's very important for perineural tumor spread that we'll talk about tomorrow. And this is a way station for perineural tumor spread at the deep face. And it's a direct communication. It goes down to the oral cavity, up to the orbit, and then intracranially along that rotundum canal and the pterygoid-ovidian canal. So it connects all of these areas. So this is a pterygopalatine fossa, connects to the nasal vault. The palatine canal goes down towards the hard palate. The pterygomaxillary fissure goes down to the infratemporal fossa, and you have the inferior and supraorbital fissure. So this is the pterygopalatine fossa on the axial view between the maxillary sinus and the pterygoid plate. So we want to see good fat at that location, and if we're thinking about perineural tumor spread, especially with skin cancer at the face, we look very closely at the pterygopalatine fossa. So we have rotundum and the pterygoid-ovidian canal going back, so that rotundum is where V2 is going. So this is the high-heeled footprint of the skull base where V3 is going down inferiorly. So we have an oval part of the high-heeled footprint, that's ovale, and the spine is spinosum. So if you think about really big high-heeled shoes, that's our ovale at that level. So on T2, we see nicely at the pons those big fibers of 5 coming out anteriorly through the pores trigeminus to go into the Meckel's cave. Those fibers should not enhance. We usually don't see enhancement of the cisternal segment of any of those cranial nerves. We don't see enhancement of the trigeminal cistern or Meckel's cave. And then extracranial head and neck, this is V3 below ovale. So if I find my condylar head at the TMJ and I go a centimeter medial and a centimeter anterior, that's how I find V3 under ovale at that level. And the T1, before contrast, you see the nose is dark here, the nose, so this is before contrast. We nicely see the normal fat around the V3 trigeminal branch inferiorly under ovale. So that branch goes out and joins into the mandible at this lingula, the little tongue of bone at that level, and we have sensation there to all of our teeth as it comes out the mental foramen up anteriorly to provide sensation to our jaw and our chin anteriorly. So in the coronal view, here's the pons. So here are these big fibers of 5 above the IAC and at the high CP angle. And there's a lot of redundancy of this. So when we think about mandibular teeth, like if you're getting mandibular teeth work done, you can inject at that one place at the lingula, and all of your teeth go numb, and your lip goes numb, and you drool from that side. But if you're getting maxillary teeth work done, you have to inject over and over again because there's a lot of redundancy on V2 to where those maxillary teeth get done. So that's the anatomy we're looking at. So again, that's our trigeminal nerve. So what pathology can happen along that? Because of the anatomy, the pathology can sometimes look very differently along that course. And there's a difference sometimes we talk about between trigeminal neuropathy, any pathology of the trigeminal nerve, and trigeminal neuralgia, acute facial pain that's chronic and debilitating. And those patients are in a lot of pain and discomfort. They are suicidal. It is very bad. That's trigeminal neuralgia. But trigeminal neuropathy is any pathology of the trigeminal nerve at all. So with trigeminal neuropathy, that's any dysfunction of the trigeminal nerve, can be sensory or motor. So we have facial pain or numbness or weakness of the muscles of mastication. So here's a nice axial T1 where we see denervation changes of those muscles. So denervation changes of the muscles of the face are sometimes complicated, just like of the tongue. Very early, the muscles may look big, and they enhance and may be bright on T2. And that enhancement in the T2 signal goes down as the fatty replacement goes up, and the muscles kind of shrink down. So here we see fatty denervation changes of this musculature. That should be the lateral pterygoid that we see normally right here. So all those muscles of mastication are being fed by V3 down inferiorly. So this is a trigeminal neuropathy case where we have denervation of that musculature. So for trigeminal neuropathy, MR is usually our modality of choice. We look at the T2 for the brainstem and the heavily T2, and we're doing fat saturation with post-contrast. We're thinking about perineural tumor spread. We want to look for those denervation changes in those muscles of mastication, and we'll talk about perineural tumor spread more tomorrow and how we think about this common pathology of skin squamous cell carcinoma. So what normally causes neuropathy? Well, we have cranial nerve V2 and V3 perineural tumor spread. Then vascular loop syndrome is more likely to present with a trigeminal neuralgia, acute facial pain that's really chronic and bad. But we can see schwannoma or meningioma that may happen along the nerve. With perineural tumor spread, I see it more in my practice along V2 than V3, and then the facial nerve. But we look very closely at that anatomy, especially the pterygopalatine fossa, when we're thinking about perineural tumor spread there. So here's an axial standard CT in the correlating bone. We want to see normal fat at that pterygopalatine fossa, and here we've replaced that fat with soft tissue, and we see abnormal enlargement along the rotundum canal, and the canal is enlarged here. And we see along that tube perineural tumor spread going back along V2 to get back to the cavernous sinus at that level. So we can have V3 perineural tumor spread also. Here's a coronal graphic. If we have a tumor that's near the jaw, it may get up on V3 and go up through a valley to get to the trigeminal cistern above that and the semilunar ganglion. So here's a nice correlating case with that graphic. This is a coronal T1 post-contrasted, and we see a lot of enhancement along V3 and going up to ovale at that level. So the nerve should not enhance, but it's normal to get some enhancement around the nerve from the pterygoid venous plexus. So if we have big thickening and the entire nerve is enhancing, that's abnormal at that level. We think about perineural tumor spread. And we see enlargement again on the CT. So you see how big ovale is on this side compared to the other normal side. So we see enlargement of the foramen, and we see abnormal enhancement along the nerve with perineural tumor spread. Vascular loop syndrome we think about with neuropathy, but it can also happen with trigeminal neuralgia. And this is where we want a vessel significantly pushing or displacing on the cranial nerve right at the root entry zone where it comes in. We often have arteries and veins along the cisternal segment of cranial nerves, but if you have a vessel that's pushing right at the root entry zone and is displacing the nerve, then we think about that's confirming a vascular loop syndrome in that case. So at a CSF thin bright sequence, if you have a blood vessel that is significantly pushing that nerve out of the way, especially if the nerve may atrophy over time, that's a great case for a vascular loop syndrome. And we might see denervation changes of the muscles of mastication depending on which branch of V3 we're affecting at that level. So next we have schwannoma. With all these cranial nerves that we talk about, we may get a nerve sheath tumor that's extending along the nerve itself. And that's a bilobe mass. And anywhere a schwannoma is, it has the vector of spread along the nerve. So if it's along the course of V3, going along in the cisternal segment and into the trigeminal cistern and down V3 inferiorly, we see that vector of spread of the nerve. And if it looks benign and avidly enhancing, when schwannomas get big enough, they have intratumoral cysts, we think about schwannomas in those cases. When they're really big, it's hard to tell sometimes exactly where that lesion originated, but we think about that extending along the course of the nerve. So this was a very big V3 schwannoma that was going up through ovale, so very big enlargement of ovale at that level. So next we have meningioma. So we have an extraaxial dural-based mass with dural tails. That's a good appearance for a meningioma. If a meningioma is going along the skull base and it goes over foramen, it may extend down through that foramen. It can go down V3, go through ovale along V3, or if it opens up to the porus trigeminus, the opening of the trigeminal cistern or Meckel's cave, it may go into Meckel's cave at that level. So this was a meningioma, extraaxial dural-based mass with dural tails, and you see benign according and compression of the brain, but this one is extending into the trigeminal cistern at that level. But it's very different than the vector of spread we see with a schwannoma along the course of the nerve. Other less common causes, brainstem lesions, METs, and infectious inflammatory processes we might see. So here's an axial gradient, and we see old blood pushed to the periphery. We might see multiple fluid levels. But again, anytime we have an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ. So if we have pathology in the pons, that could present with a trigeminal neuropathy or trigeminal neuralgia. So we think about those 4 central cranial nuclei that contribute to that. And again, the central cranial nerves, 5 through 8, we think about their nuclei being in the pons. So if there's pathology in the pons, we may have cranial nerves 5 through 8 having pathology and clinical symptoms. If we have MS, if you have a lot of patients with multiple sclerosis, we may have a demyelinating plaque near one of those cranial nerves, and we might get ischemia near those levels. So all of those lesions could present with a trigeminal neuralgia or neuropathy. Now, trigeminal neuralgia, tic-douloureux, that's facial pain, unilateral stabbing pain, usually in V2 or V3 distribution. Patients often over 60, and sometimes it is debilitating. These patients are suicidal, it is constant, and they are constantly fighting this pain that they have all the time. And we are usually looking for irritation at the root entry zone. So the best study for that is going to be an MR with an MRA, but we want to focus on all that anatomy. So again, all the way along that course, we have to look at the pons, the prepontine segment, the trigeminal cistern, and think about where V1, V2, and V3 is going all the way along that course for our trigeminal nerve. So vascular loop syndrome is the most likely pathology to be causing trigeminal neuralgia or tic-douloureux facial pain. And 90% of the time, if we do see a pathology that's causing trigeminal neuralgia, it is a vascular loop syndrome. And again, around the cisternal segments of all these cranial nerves, we see arteries and veins, flow voids around there. So depending on which vendor you have and which technique, the CISS, constant imaging, is kind of difficult because sometimes the blood vessel flow void is bright. I prefer the space on my scanners because it makes the flow voids on the arteries and veins all very dark, and you can differentiate better from the blood vessels. So the KISS imaging sometimes causes banding artifacts in the vestibule. You see these little curved lines. I prefer the space, but whatever sequence you have on your vendor, KISS, space, Fiesta, T2FSE, whatever your CSF bright sequence you're doing, you're looking for a blood vessel that's right at the root entry zone of the nerve that is significantly pushing and displacing the nerve out of the way. So again, if we see a case where the trigeminal nerve is coming out of the pons, and here's a big loop, so we're often looking at pica, aica, or a dolichoectatic vertebral basilar vessel, a big curvy basilar artery that's pushing right at the root entry zone of the blood vessel itself. So when we're thinking about that pathology, that's what we want to look for in these cases. We can more rarely get meningioma and other pathology that may happen along its course. Here's another case of a meningioma that's right there at the cisternal segment and the prepontine cistern, and we see the trigeminal nerve going right through that. So the meningiomas in the prepontine cistern and the meningioma is in the trigeminal cistern or Meckel's cave at that level. Again, we can't have multiple sclerosis present with trigeminal neuralgia. Here's another case with multiple MS plaques. And again, those central cranial nuclei 5 through 8, we think about their central nuclei being in the pons. So if we have pathology in the pons, they can present with those cranial nerve deficits. So we want to think about that anatomy all the way along its course. So we remember our fifth nerve gang sign, yo, when we see our other head and neck buddies. And we remember that anatomy. We want to image all the way along its course. And again, the big deal with all these cranial nerves, you're going to hear in these next couple of lectures, anytime you have an isolated cranial nerve deficit, we want to image from the origin nucleus all the way out through the face. So that's a quick review of the trigeminal nerve and that anatomy and pathology, and I thank you very much for your attention.